You can start.
Uh, Good evening to everyone listening to the lecture. I'm going to be talking about a different topic today. Today it's a physiological topic. It's called Modified Starling Principle and its clinical applications. At the outset, I'd like to say that it's a slightly complicated topic, but I'll try to simplify it as much as I can. I'm Srikanth here, and right now I've completed my DM in critical care medicine and CMC Vellore. So let's start. Yeah, so this is the outline of my topic. First, I'll talk about the basic body fluid composition, which is our traditional and Starling model understanding, and then we'll go through its limitations. We'll then look at the revised Starling principle and what are the clinical applications of this principle in our day-to-day clinical practice. So this is the body fluid composition that we commonly learn. The total body water is approximately equal to 60% of the body weight. For a 70 kg person, it's about 42 liters, and one third of this is extracellular fluid, and two-third of this goes to the intracellular fluid compartment. So for 42 liters, one third would be 14 liters ECF and 28 liters of ICF. And this ECF is then divided to one fifth, that is 20% intravascular volume, would be divided into the intravascular volume, and the rest would be extravascular, which is about 12 liters. So our general understanding is that if we give some colloid, that will remain in the intravascular volume. So if I give 1 liter of colloid, it will all remain within the intravascular volume. So albumin, 3% saline, hydroxyethyl starch would remain in the intravascular volume. Whereas if you give crystalloid, like normal saline or a balanced salt solution, it would all distribute in the extracellular fluid. That means if I give 1 liter of NS or RL, about 200 ml will remain in the intravascular volume and the rest will be distributed to the extravascular volume. So the basic ratio of the intravascular retention of these fluids, if you compare crystalloids to colloid, basically it would be about 1:5. So if you give 1 liter of crystalloid, only about 20%, that is 200 ml, will remain in the intravascular volume. Whereas if you give hypotonic fluids like 5% dextrose, it will get distributed in the whole body water, the total body water, and the amount remaining in the intravascular volume would be only about 40 to 50 ml. So, in reality, what actually happens is in studies like the SAFE study and the Albio study, what they've seen is to get the same intravascular distribution of colloids and crystalloids is not actually 5 is to 1. The ratio is more close to 1.1 is to 1 or 1.5 is to 1. So, the thing that we have noticed is the response, the clinical response to fluid resuscitation to colloids is not as drastic as we initially thought. So this is one of the few things that is explained by this concept. So let's start off with the Starling principle. So the Starling principle basically states that transvascular fluid exchange depends on a balance between hydrostatic and the oncotic pressure gradients in the capillary lumen and the interstitial fluid. So the hydrostatic pressure is the pressure exerted by the fluid column within the vessel. For example, the hydrostatic pressure of the blood vessel pushes the capillary hydrostatic pressure, which is denoted as PC, is the pressure which pushes fluid out from the blood vessel into the interstitium. Then you have the oncotic pressure, which is the pressure exerted by the solute. Now, this is a pulling force. So, the oncotic pressure is exerted by proteins which do not cross a membrane, the semi-permeable membrane, which is in the endothelium. So, that is denoted by pi c here, and it is a pulling force towards the blood vessel. The same goes for the interstitium. Interstitium exerts a pushing force called the interstitial hydrostatic pressure, and a pulling force called the interstitial oncotic pressure. And the balance is what determines the net filtration rate. So net filtration rate is the balance between the difference between the hydrostatic pressure gradient and the oncotic pressure gradient. And this is what determines how much fluid transfers from the blood into the interstitium. So we need to understand a concept called the Staverman's reflection coefficient to proceed any further. What this is it describes the leakiness of a membrane to a solute. It depends on both the membrane and the nature of the solute. For example, if the Staverman's reflection coefficient is zero, it means that the solute is completely permeable to the membrane. For example, small solutes, for example, like let's say sodium, can easily pass through most membranes. So this will have a Staverman's reflection coefficient of zero. So you need to understand that only solutes that are partially permeable or completely impermeable will exert any oncotic force, because if it is completely permeable, the concentration gradient would not be there. So there would be no oncotic force. So another Staverman's reflection coefficient that you need to remember is 0.9 for mannitol to the blood-brain barrier and 1 to 3% saline to the blood-brain barrier. So basically what it states is that mannitol is partially permeable to the blood-brain barrier. So some of the mannitol will be passing the blood-brain barrier into the brain interstitium, This is what is responsible for something called the rebound phenomenon. When you suddenly stop mannitol, it will start pulling fluid into the brain parenchyma. And the Spearman reflection coefficient 1, which means 3% saline, does not have this problem. And other solutes like albumin to the glomerulus is totally impermeable. Why this is important here is we need to apply the Spearman's reflection coefficient to our previous formula. What we get is the hydrostatic pressure gradient minus the oncotic pressure gradient should be multiplied by the sum of all the Spearman reflection coefficient multiplied by the oncotic pressure gradient. Because if it is completely permeable, that is, if it is zero, it does not exert any oncotic pressure gradient at all. Only the solutes which are partially or completely impermeable will exert a oncotic pressure gradient. So this is the final equation that you will get. This is called Starling-Landis equation. So it puts in some constants to fill in the gap, and you get LP into S. LP is basically the hydraulic conductivity of the membrane, which is the nature of the membrane, and the surface area of exchange multiplied by the previous formula that we have previously discussed. So this is the Starling-Landis equation as per the conventional Starling's principle. So, what does the Starling principle state at the capillary level? What happens is our blood has a fixed amount of albumin. So, the oncotic pressure is fixed in the body. It's around 25 millimeters of mercury. The interstitial hydrostatic pressure and the oncotic pressure is very minimal. As per the traditional classical Starling definition, it's close to 1 millimeter of mercury. So, both of them cancel each other out. So, the only thing which will determine whether filtration is happening or absorption is happening is the pressure at the arterial and venous end of the capillaries. So at the arterial end, you will see that the capillary pressure is about 32 millimeters of mercury, which is higher than the oncotic pressure of 25. So you will get a net filtration effect. And then at the venous end, you have a lower pressure than the oncotic pressure. So you have 15 millimeters mercury, which is lower than the oncotic pressure. So you will have net absorption happening. And whatever is remaining fluid in the interstitium will be taken up by the lymph channels into the venous end. So this is the traditional Starling principle and how it explains filtration at the capillary level. So now let's look at what are the problems, limitations with the classical Starling principle. So when we start off, we need to understand something called the line of equality. So basically, it is a point at which neither filtration or absorption occurs. So this is just a mathematical definition. So to know whether to know where what the point is where neither filtration nor absorption occurs, the capillary hydrostatic pressure should be equal to the sum of all opposing forces. Okay. So if I plot a graph between capillary hydrostatic pressure and sum of all opposing forces, the line bisecting this graph is basically the line of equality, where there is neither absorption nor filtration. Anything towards the left side of this line is basically where filtration is happening. Anything towards the right side of this line is where absorption is happening. This is important because this graph has been plotted experimentally in multiple membranes across the body. So this is the graph that we got, and almost all the tissue, all the membranes actually have filtration but no absorption, except a few, mainly only two exceptions that are renal and intestinal mucosa. Otherwise, everywhere else only filtration happens, and this is completely against the classic Starling law because classic Starling's principle explains that there should be absorption at the venous end of the capillary. So this is one thing which goes against the experimental observation. So consistent absorption has never been demonstrated in most capillaries in the body. The second thing is a gravity gradient. So I told you the main opposing force for filtration is the oncotic pressure, which is at about 25 millimeters of mercury. And at the arterial end, you have pressures greater than oncotic pressure. At the venous end, you have pressures lesser. But as you come down below the level of the heart, you obviously have an increase in the arterial and venous pressures of the capillary. So below 10, more than 10 centimeter below the heart level, venous pressures will exceed 25 millimeters of mercury, and lower extremity edema will be inevitable because lymphatic channels can only bring in a certain amount of a limited amount of fluid. So eventually, you will have a lot of drainage, and then lower edema would have been inevitable if you are following the classic Starling principle. This is also not explained by the classical Starling's law. The second thing that we need to understand is a low filtration paradox. So, if there was so much of drainage happening, so much of filtration happening, the lymphatic channel should be draining a huge amount of fluid, which is expected to be somewhere around 40 liters per day. However, the observed turnover of lymph is only about 8 liters per day. So, that suggests that the actual filtration must be much, much lower than what we had calculated as per the classical Starling principle. And what we have also realized is the oncotic pressure of the interstitium is not really negligible. Previously, I told you it's about 1 millimeter of mercury, but when experimentally found that it is close to 15 millimeters of mercury because a lot of albumin is actually stuck in the interstitium. About 60% of plasma proteins are actually extravascular, but considering that there's a large amount of fluid dilution happening, you will have lesser concentration. So, has about 7 gram per deciliter of protein, whereas interstitial fluid has 2 to 3 gram per deciliter of protein, which should exert about 15 millimeters of oncotic pressure. So this is also completely against what classical Starling has explained. Also, when they try to increase the oncotic pressure of the interstitium by injecting protein-rich fluid into the interstitium, they never really saw any increase in filtration rate. So what they found is that the interstitial oncotic pressure does not affect filtration at all. So this also goes completely against our classical Starling understanding. And also in clinical practice, if you see, there is no benefit of correcting hypoalbuminemia in ICU patients. So you have a lot of critically ill patients with hypoalbuminemia, and correcting it really does not have any benefit clinically, and no study has actually shown any benefit of albumin in terms of reducing extravascular lung water by pulling in fluid and causing, reducing edema. So all of that goes against our classical Starling understanding of the fluid balance that happens to the critically ill patients. So now let's come to modified Starling principle. The modification is very simple. It just adds in one layer, which is the understanding of the role of endothelial glycocalyx in transvascular fluid filtration. So we'll see how that changes our understanding of the whole shifts. So what is the endothelial glycocalyx? It is basically a hydrogel layer of membrane bound proteoglycans and glycoproteins which line the endothelium. So there are three major components: the proteoglycans, which form the central core. Examples are syndican and glypican. You have glycoproteins, which includes lots of addition molecules like selectins, integrins, and you have glycosaminoglycans, which are the bulk of the hydrogel membrane, and they provide a negative charge. This includes glycosaminoglycans like heparin sulfate, hyaluronate, etc. So this is how it looks. The endothelial glycocalyx has a fixed component. The fixed component is primarily the proteoglycans, which are the syndicants and the glyphicans. And then there's a dynamic component, which forms the bulk of the endothelial glycocalyx, which is the glucosaminoglycans. So glycosaminoglycans, which traps a lot of albumin and addition molecules along with it. So this is the basic structure of the endothelial glycocalyx. So if you look at the electron microscopy view, this is how it looks. It looks like a grass-like membrane on top of the endothelium. So this holds a good amount of fluid within it. This is the glycocalyx on top of the endothelial cell. So what are the functions of the endothelial glycocalyx? There are many proposed functions, but for this lecture, I'll primarily stick to the reserve and barrier function. What it means is that the volume because it's a hydrated membrane, it carries about 700 ml to 1700 ml. Up to 1.7 liter of fluid is there within this membrane itself. And the average thickness of this membrane is about 2 micrometers in the body. It forms a non-circulating reserve. So along with the blood, it forms a non-circulating reserve of intravascular volume, which can help in the fluid shift. For example, when you have a reduced capillary hydrostatic pressure, fluid from the endothelial glycocalyx will come into the circulating fluid, circulating blood, and then it will expand your intravascular volume. So it has this reserve, and it also has a barrier function. So because it is impermeable to molecules more than 70 kilodaltons, so and negatively charged, because glycosaminoglycans are negatively charged, it repels negatively charged proteins like albumin from passing through the membrane. So this is what the modified Starling principle describes. So the only difference that has happened is that there is a semi-permeable endothelial glycocalyx which repels albumin and such proteins from passing through. So what it creates is a single layer below it, which is the subglycocalyx layer. So this is a very narrow layer which has no proteins at all, primarily because one, the endothelial glycocalyx prevents any albumin from coming into the subglycocalyx layer. But you would also notice that the subglycocalyx layer is continuous with the interstitial fluid layer. And there is nothing stopping the proteins from coming into the subglycocalyx layer. But that's not true. The only thing which stops the proteins from actually diffusing into subglycocalyx layer is the filtration that is happening. So this filtration through a narrow channel pushes out protein from the subglycocalyx layer and makes the oncotic pressure of the subglycocalyx layer zero. So now the exchange is now happening between the intravascular volume and the subglycocalyx layer, which has no protein at all. but the hydrostatic pressure of the subglycocalyx layer is equal to the hydrostatic pressure of the interstitial layer. So the only thing which is actually changing is the oncotic pressure of the subglycocalyx layer, and nothing else changes. And this explains a lot of what I had explained and told you as a limitation of the classic Starling principle. And all the absorption that happens through the lymphatic channels. So basically, whenever you have edema, according to the modified Starling principle, it is always due to lymphatic failure and nothing else. Okay, so all the fluid that is reabsorbed in the body is happens from the tissues and the interstitium happens from the lymphatic channels and nothing else. So, how is the subglycocalyx layer kept protein free? Number one, the high reflection coefficient of the endothelial glycocalyx because it is impermeable to albumin. Two, because the ultrafiltrate flow opposes any protein diffusion, like I showed you. And the structure of the interendothelial cleft, because it is so narrow, it exaggerates the gradient, the pressure gradient. Even a 1 centimeter water pressure gradient is sufficient to prevent any protein diffusion happening into the subglycocalyx layer. So this is how the formula changes. The formula only change that happens is the pi I, which is the interstitial oncotic pressure, now changes to subglycocalyx oncotic pressure. So now let's see how this change explains a lot of the limitations that we discussed for the classical Starling's law. So this is how we describe the classical Starling. So this is the net filtration force downwards and the net absorption force upwards. So the net filtration force is the capillary hydrostatic pressure gradient and the oncotic pressure gradient you are seeing above. But the only thing that has changed here, we know that the oncotic pressure of the interstitium is closer to 15 millimeters of mercury. Now that has changed to 0 because it is come to subglycocalyx oncotic pressure. So the absorption force has quite significantly increased now, and hence the net filtration is much lower than we actually measured from the classical Starlings. So that is why the net filtration happens only about 8 liters per day, which is what we observe as a lymphatic flow for a normal human being. So this explains why the net filtration is so low, and all the absorption that is happening through the lymphatic channels. That's about 8 liters per day. So that is one thing which is solved by the modified Starling principle. Secondly, let's say you have a state where you have sudden decrease in capillary hydrostatic pressure. Let's say the patient has bled out quite a bit, or maybe you have given vasopressors like noradrenaline. Noradrenaline will cause precapillary sphincter constriction that causes reduction in the capillary hydrostatic pressure. Another thing you can do is maybe give a albumin bolus, which will suddenly increase the oncotic pressure of the plasma. So what will happen then? So there will be a transient absorption which will happen through the subglycocalyx layer, from the interstitium through the subglycocalyx layer into the blood. But then this causes the albumin to be pushed into the subglycocalyx layer. So this suddenly increases the oncotic pressure of the subglycocalyx layer, which then pulls fluid back into the interstitium, and this causes a net filtration again. So whatever absorption that happens when there is a state of low hydrostatic capillary pressure or high oncotic pressure, you eventually end up only having filtration and no absorption. Every absorption that happens is actually transient. So, like I described, when you have a low capillary hydrostatic pressure, which may be due to hypovolemia or use of vasopressors like noradrenaline, or you gave a high albumin infusion which increases your oncotic pressure, there is a transient reversal of the pressure gradient which causes absorption. And this absorption first causes autotransfusion of up to 500 ml from the endothelial glycocalyx layer itself. So this is how you can possibly describe that when you give vasopressors like NORAD, even at a low dose, it causes autotransfusion of fluid back into the intravascular space from the endothelial glycocalyx. Other than that, there is also the protein invasion from the interstitial fluid into the subglycocalyx, which increases the oncotic pressure of the subglycocalyx, and then filtration is resumed. So this is why it describes the no absorption rule very clearly in the revised Starling principle. So other than this, we'll also look at the inverse gradient between the capillary hydrostatic pressure and the oncotic pressure of the subglycocalyx. So basically what we have understood is that when capillary hydrostatic pressure goes up, the filtration goes up. So the subglycocalyx oncotic pressure comes lower and lower. So that's what happens in the experimental settings. So when we increase the capillary hydrostatic pressure, the pi g, which is the oncotic pressure of the subglycocalyx, decreases. So let's assume that the capillary hydrostatic pressure is 25 millimeters of mercury. which is the physiological capillary hydrostatic pressure, and at that time the oncotic pressure of the subglycocalyx is close to zero. So the net filtration gradient is close to 5 millimeters of mercury. But let's say there is a sudden drop in capillary hydrostatic pressure. Now the proteins will suddenly diffuse into the subglycocalyx layer, and the aquatic pressure of the subglycocalyx increases, let's say up to 10 millimeters of mercury. So net filtration gradient is still the same. So what happens is when there is a drop in capillary hydrostatic pressure also, the aquatic pressure, I mean the net filtration pressure does not change at all. So this leads us to a graph between the filtration and the capillary hydrostatic pressure. So what you're seeing in the y-axis is the filtration pressure, and what you're seeing in the x-axis is the hydrostatic pressure of the capillaries. So because from 0 to 25, you will not see any increase, because as the capillary hydrostatic pressure increases, the subglycocalyx oncotic pressure decreases, hence the net filtration pressure remains more or less the same till a point when you reach the subglycocalyx oncotic pressure becomes zero, and at that point there is a sudden increase in filtration. So this is what is described by the modified Starling principle, that up to a physiological range there will be no increase in filtration despite increase in capillary hydrostatic pressure, and only after a certain J point when the oncotic pressure in the subglycocalyx becomes zero, there is a sudden increase in filtration that happens. So any fluid, for example, if the patient is in shock, any fluid that you give will remain in the intravascular space, because if it has to extravasate, it has to be filtered through the from the blood, from the intravascular space. So what we are seeing is when the capillary hydrostatic pressure is low, the filtration pressure does not change much. It doesn't matter what fluid you give, it will remain in the intravascular space. This is what explains why whether you give colloid or crystalloid in a patient who is in shock, the ratio will remain almost similar. That is 1 is to 1.5, which is what is experimentally seen in multiple studies like SAFE and Albios. Only if you have supranormal capillary hydrostatic pressure, only then excess filtration will start happening. So let's also look at what the oncotic pressure affects, how the oncotic pressure affects the filtration. So what we have seen experimentally is that oncotic pressure does not reverse filtration, but it opposes it. So you can see here that when the oncotic pressure is higher, which is the pink graph, you can see that it is actually reducing the amount of filtration, but it is not really causing any absorption. So that is the impact of having the colloid oncotic pressure in a patient who is in shock. So it doesn't really cause any absorption, but it might reduce your filtration. The next thing is, let's say this patient has a capillary hydrostatic pressure somewhere close to 18. This is what I marked in the dot here. And now this patient has gone into sepsis with severe capillary leak. What happens during sepsis and severe capillary leak is that the J point shifts upward and towards the left. This is because the reflection coefficient, that is the membrane permeability, suddenly increases, and at that point, with the same hydrostatic pressure, you're very close to the J point. That means you're very close to a point where you have a lot of filtration happening. So at this point, what you can do is give vasopressors, because vasopressors like norepinephrine at a low dose can cause precapillary sphincter constriction, and this can reduce the capillary hydrostatic pressure and prevent further capillary leak from happening. So that is why early vasopressors can help fluid stay within the intravascular space. And the experimentally, what is found is that the doses required for this is about 2 to 3 mics per minute. It does not require a huge dose. It is a very small dose which causes this effect. So when a patient comes with sepsis with capillary leak, early initiation of vasopressor can actually help prevent further edema in patients, prevent further edema and retaining fluid within the intravascular space when the patient is in capillary leak. So this also is reflected in multiple recent papers that initially they used to talk about filling the tank and then squeezing it with vasopressors. But now the concept is more about starting vasopressors early along with your fluids and limit the total amount of fluids that you give, because the net positive balance ends up causing harm to the patients. So we'll also discuss why oncotic pressure is not targeting oncotic pressure is not really beneficial. So if you look at what we have seen till now, there is no steady state absorption that happens in patients. Septic and non-septic patient may actually have similar oncotic pressures despite having low albumin. This is because a lot of other inflammatory proteins go up during sepsis. And during capillary leak states, the Snellman's reflection coefficient for albumin reaches zero in severe capillary leak. So targeting oncotic pressure then doesn't matter at all because even, I mean, giving albumin would not be useful in that state. It can also cause possible harm in the sense if you give a sudden increase in like a very high osmolar fluid, it can actually increase your glomerular capillary oncotic pressure. So when you're increasing the glomerular capillary oncotic pressure, it opposes your GFR, that is a glomerular filtration, and that reduces GFR and can cause a worsening of acute kidney injury. We have already seen studies showing significant increase in AKI with fluids like hydroxyethyl starch. There is also some observational data that untoward use of 20% albumin, like the CRICO study, has shown that use of 20% albumin can increase the risk of acute kidney injury. So, targeting oncotic pressures in patients with septic shock may not be very useful. And like we thought, the initial body fluid composition is not as simple as we initially thought that we had discussed in the first few slides. For example, the interstitium is not really the same. There is two types of interstitium. There's an expansile interstitium, like that in the skin and soft tissue and muscle, and there is an interstitium which does not really participate in fluid exchange because it is covered by a very hard structure. For example, the bone marrow is covered by a hard marrow. It doesn't really have any space to expand. The spleen has a very thick capsule. The kidney has a thick capsule. So the expansion is then limited by these factors. There's also a concept of triphasic interstitium. That is, there is three phases for the interstitium. The aqueous phase, which is about 1% of interstitial water. It is free fluid and it's free flowing and expands up to 50% during edema. And this is what actually equilibrates faster as compared to the hyaluronate gel phase, which is about 99% of the interstitial water, and it does not really equilibrate fast. So this ends up causing a non-pitting edema, whereas the aqueous phase of the interstitium causes pitting edema in patients who are fluid overloaded. Then there is a collagen phase, which actually channels the flow of aqueous phase within the interstitium. So this is the diagram from Guyton and all of the same. You can see that there are free fluid vesicles within the interstitium, which forms the free flowing phase. There's a gel-like gelatinous phase, and then there's a collagen phase in between. So what we think of for normal fluid exchange is not that simple as just the interstitial volume expanding. So if you have slow filtration, it increases only the aqueous phase. So this can be easily cleared by lymphatics and diuretics. However, when you have sudden inflammation and rapid filtration, this degrades the extracellular matrix, and that ends up causing expansion of the gel phase. This causes a very difficult to treat edema. So what what we have understood till now is that the intravascular space actually exchanges with the expansile interstitium, and in the expansile interstitium, it only exchanges with the aqueous phase of the interstitium. So it is much more complex than just saying that intravascular space exchanges with the interstitium and then the intracellular fluid. And we also have learned that the intracellular fluid is very tightly regulated by something known as a volume regulatory anion channels, which does not participate in fluid exchange at all. So intracellular fluid does not really participate in fluid exchange because they are tightly regulated by these volume regulatory anion channels, and it requires a significant pathology for them to be deranged. For example, for the blood-brain barrier disruption to cause cerebral edema, that intracellular edema takes a lot of inflammation and damage for it to occur. In physiological states, the intracellular fluid does not participate in fluid exchange at all. So the modified fluid composition is much more complex than we initially thought of, and this the modified Starling principle makes sense of some of it. So it is an experimental concept. It needs clinical validation, but it explains a lot of drawbacks of the classical Starling principle. So the endothelial glycocalyx is the semi-permeable membrane which is responsible for filtration. There is no benefit in targeting oncotic pressure. Any edema that happens is because of lymphatic failure, and early vasopressors and low fluid balance is said to be the gold standard in septic shock at present. Thank you. I hope you understood. It's a very complex topic, I know, but it took me a long time to understand all of this. So I'm not sure if I was very clear with explaining this.